Early forms of treatment arose from the belief that mental disorders were caused by evil spirits. In some cases, large holes were cut in a person's skull so that demons could be driven out. Other treatments tried to calm the demons with music, chase them away with prayers, or drive them out with starvation or flogging. Beginning in the 16th century, asylums were established throughout Europe. Individuals who had committed crimes, people with epilepsy, and even the poor were all institutionalized along with people experiencing severe mental illness. The goal of asylums was to remove these individuals from society. The result was barbaric treatment, including filthy living conditions, the use of chains and shackles, and many other forms of abuse. Gradually, reforms emerged. The French physician Philippe Pinel, for example, was put in charge of the Parisian hospital system in 1793. Pinel wanted to remove the patients' shackles and chains and talk to them, give them exercise and fresh air. Patients benefited from this more humane treatment, and many were able to leave the hospital. Around the same time, William Tuke, an English Quaker, founded the York Retreat, where people with severe mental disorders could engage in reading, light manual labor, and conversation. 25 years later, in the United States, a group of physicians opened the Hartford Retreat, a small, semi-public institution that focused on using a moral curative approach in a tranquil and caring environment. But these reforms were not to last. Industrialization, the expanding population, the rise of large cities, and the resulting pressures to admit more and more people all contributed to replacing moral treatment with larger institutions providing little more than custodial care. Also, in the second half of the 19th century, the optimism surrounding moral treatment was replaced by the eugenics movement, which viewed mental disorders as a defect that required institutionalization and even forced sterilization. Public residential institutions in the US continued to grow in size and number from the 1880s until 1955. This period was followed by a dramatic reversal with the introduction of antipsychotic medications in the 1950s. The classical antipsychotic medications, such as Thorazine, Haldol, and Stelazine, effectively reduced symptoms of schizophrenia, such as thought disorder and hallucinations. Unfortunately, these drugs were less effective in treating symptoms like flat affect and the inability to feel pleasure, which were addressed 3 decades later with the introduction of atypical antipsychotic medications. Prior to antipsychotic medications, 2 out of 3 patients with schizophrenia spent most of their lives in a mental hospital. By the 1980s, the average stay was about 2 months. In addition to antipsychotic medications, movement away from long-term hospitalizations was made possible by the Mental Retardation Facilities and Community Mental Health Centers Construction Act, signed by President John F. Kennedy in 1963, which provided federal funding for community mental health centers.
This tragic human waste, which of course affects not only the child but the family which is involved, can and must be stopped. And I think we have an obligation as a country, especially a country as rich as ours, especially a country which has so much money to spend on so many things which may be desirable but maybe not essential in every case. We certainly should have the resources to spend to make a major effort to see if we can block this, stop it, and cure it.
This legislation dramatically changed how mental health services were delivered in the United States and started the process of deinstitutionalization, the closing of large asylums achieved by providing funding for people to stay in their communities and be treated and supported locally. Today, instead of asylums, there are psychiatric hospitals run by state governments and local community hospitals focused on short-term care. But deinstitutionalization was at best a partial success. Many individuals have not found appropriate care and support in community settings. As many as 200,000 people with severe mental illness are homeless in the United States, and an equal number are in jail, often for minor crimes. Of course, most people experiencing mental disorders have not faced hospitalization. If someone is feeling depressed, struggling with substance abuse problems, needs support coping with personal challenges, or wants to attain personal growth, they might try psychotherapy. Psychotherapy is a general term for treatment that includes talking with a mental health provider. And it's been the most common type of treatment since the early 1900s when Sigmund Freud developed psychoanalysis. In a psychoanalyst's office, you might see a person lying on a couch speaking of childhood memories and the therapist using free association or dream analysis to help uncover unconscious thoughts and promote insight. Therapies stemming from Freud's original psychoanalysis are known as the psychodynamic therapies. The terms psychoanalytic and psychodynamic are often confused, but you can think of psychoanalysis as Freud's particular therapy, while psychodynamic theory is a family of approaches that descended from it. Like psychoanalysis, psychodynamic therapy focuses on helping people gain insight on the impact of unconscious internal forces, early relationships, and critical childhood experiences. Its hallmarks include self-reflection and self-examination, and the use of the relationship between therapist and individual as a window into problematic relationship patterns in a person's life. Now, other types of therapy have grown out of the existential and humanistic traditions, and focus on people's capacity for making rational choices, achieving self-acceptance, and attaining their maximum potential. Psychologists who take an existential humanistic approach are guided by the idea that people must take responsibility for their lives and their actions and live fully in the present. Like psychodynamic therapies, existential humanistic therapy is still insight-oriented, but it's more about promoting growth than curing illness. In the mid-1900s, Carl Rogers developed a particular humanistic technique called client-centered therapy. He encouraged therapists to provide an empathetic, genuine, and accepting environment, and to use active listening where the therapist echoes and clarifies what their clients are saying and feeling. Rogers believed these techniques helped provide a safe and non-judgmental space where people could accept themselves, feel valued, and work towards self-actualization. When an existential perspective is included, therapists help their clients maximize their potential in the face of existential thoughts and fears. Behavior therapists. Behavior therapists view negative behaviors as the problem to be solved, that all behavior is the result of learning, and that the remedy simply involves new learning. Behavioral therapists work to replace negative behaviors with more positive or effective ones. The goal is to change behavior in order to change emotions. Behavior therapy is rooted in the experiments of Ivan Pavlov and his classically conditioned dogs that drooled at the sound of a bell, and work by E.L. Thorndike and B.F. Skinner on operant conditioning, that is, changing behavior by using positive or negative reinforcement. As an example, exposure therapy is used to treat anxiety by having a person face their fears through gradual exposure to situations that they typically avoid. And virtual reality has begun to play an important role.
The idea of flooding someone with the thing that causes them distress. So a really simple example could be if you're afraid to drive or couldn't get behind the wheel.
So this is the Limbix headset.
Once that therapist knows that you're ready and comfortable to do this exposure, the therapist might start you off on a quiet street. And so you're in your virtual reality headset as a patient. And as the therapist next to me, as I'm going through this as a patient, all the while sees what I see in VR on their tablet.
What we have here is the tablet interface.
And on that tablet, they can choose that quiet street. They can also choose a busy road like a highway or a tunnel or something much more anxiety-inducing like a bridge. And so the therapist will slowly but surely gradually expose me to more and more stressful environments. And while I'm viewing these and going through that therapist is also teaching me coping techniques to be more comfortable with what I'm doing and things that I can apply to my own life when I'm actually in the car afterwards. There's much more serious examples around PTSD and other phobias as well, where exposure therapy can be really helpful.
Behavior-based therapies can actually reduce symptoms associated with specific phobias, panic disorder, traumatic experiences, major depression, and some other anxiety disorders, but it usually is improved with the help that comes from cognitive therapies. Cognitive therapy focuses on what people think rather than what they do, assuming that if you can change a self-defeating thought, you can change the related behavior. For example, people often overgeneralize or engage in all-or-nothing thinking, taking a small situation and making it huge. Cognitive techniques help people test the validity of their thoughts and replace maladaptive thoughts with more adaptive ones. I did fail that test, but that doesn't mean I'll fail out of school. Or, I failed out of school, that doesn't mean I failed out of life. Now, if you combine cognitive therapy and behavioral therapy, you get cognitive behavioral therapy, or CBT, and that focuses on present issues rather than the past and includes highly structured sessions and even homework aimed at helping people practice new skills and new ways of thinking. Patients learn to develop and test hypotheses about their problems, so they learn to try out new skills and then gather and monitor their own personal data. They become experts in evaluating the data and iterating on the process based on the data collected. And these are skills they can take with them after the therapy ends. Now, unlike the therapies we've described so far, which were developed in the 20th century, a mindfulness approach comes from the Buddhist and yoga practices. Mindfulness, or a process that tries to cultivate a non-judgmental yet attentive mental state, is a therapy that focuses on awareness of bodily sensations, thoughts, and the outside environment. Where other therapies work to modify or eliminate these sensations and thoughts, mindfulness focuses on non-judgmentally accepting them. Mindfulness draws attention away from past and future stressors, encourages acceptance of troubling thoughts and feelings, and promotes physical relaxation. In the words of Pema Chodron, an American Tibetan Buddhist nun, "You are the sky. Everything else is just the weather." It's important to remember that psychotherapy is not always experienced as just you and a therapist. There are also many groups where people who have the same experiences might gather. A classic example is Alcoholics Anonymous and other 12-step programs that give those recovering from alcoholism, drug abuse, gambling, or other addictive behaviors the knowledge that they are not alone. In these "we are all in the same boat" groups, the primary aim is to manage the challenges that all the members share and to support one another against suffering relapses. Groups are not always strangers either. Couples therapy and family therapy also have become major therapeutic movements. Psychotherapy can be delivered in person or online and by a wide range of professions, including clinical psychologists, psychiatrists, psychiatric nurses, marriage, family, and child therapists, school and vocational counselors, mental health counselors, clinical social workers, and even religious leaders. But does it work? And how do we know? Well, when an individual's perceptions or those of their therapist are relied on, not surprisingly, impressions on psychotherapy tend to be pretty positive. One study found that 89% of people said they were at least fairly well satisfied with their treatment. But of course, perceptions are inherently subjective, and the therapeutic relationship can lend itself to a positive bias. Basically, if you stuck to your treatment, then you probably liked your therapist. The therapist's perspective can also be skewed, not only in terms of a self-serving bias, but also because they may not be around to see future struggles or relapses. So how can we objectively evaluate whether psychotherapy works? The gold standard approach for treatment outcomes research is the randomized controlled trial, or RCT. These are studies in which each participant is randomly assigned to either a control group or one of the experimental groups of interest. This design accounts for individual differences and other factors. So, if people in the experimental group get better and the people in the control group don't, then the treatment made the difference. If we're testing medications, we generally test for placebo effects by giving a patient a medically neutral substance, the placebo. In principle, the same logic regarding a placebo control applies to the study of psychotherapy. In practice, though, it's not always clear what the placebo would be. Would we want to replace the placebo group to work with a therapist who listens but without warmth? A therapist who expresses warmth but provides no guidance? A therapist who offers guidance irrelevant to the person's problems? The choice between these options depends on the mechanism by which the experimental treatment is expected to work. For example, if a researcher is trying to test whether the particular skills taught in a therapeutic approach are an important aspect of the treatment, they may choose a control condition with a similar number of sessions and similarly warm therapists, but without teaching the skills. Another approach, rather than having a control condition, is to compare the treatment of interest to other standard treatments, or to a waitlist control group. The waitlist control group is just a group of people who haven't started therapy yet. There's another important way in which RCT procedures differ for psychological treatments compared to medication. When we're testing a medication, it's easy to ensure that each person gets the same number of pills and that the chemical constituents of the pills are the same for everyone. But how can we ensure in a study of therapy that each person gets the same treatment and the same dose? Investigators usually address this point by developing a treatment manual that tells the therapist exactly how to proceed during the study, what steps to take, what instructions to offer, and so on. This manualized therapy limits the degree that the therapist can improvise or adjust procedures. Sessions will also typically be audio or video recorded, with everyone's knowledge and consent, and reviewed for fidelity. This means that other research assistants familiar with the therapeutic conditions will watch the sessions and rate how well the therapists are doing with sticking with each condition as designed. In addition, we need to assure that the participants in our RCT are reasonably uniform in the problems that bring them to therapy. We would want to make certain that all of the participants were truly depressed and that their depression was not complicated by other problems that might mask the effects of the treatment. Likewise, we would probably want to make sure the participants were somewhat similar to one another in the duration and severity of their depression. Otherwise, variations from one participant to the next might prevent us from detecting the therapy's effects. Once there is a group of independent RCT studies, the data can be summarized through meta-analysis, combining results across multiple trials to see whether the treatment works and how well in a variety of settings. Meta-analyses are very helpful because they allow us to get a better picture of the treatment's typical effect rather than relying on one particular study. RCT studies usually measure either the efficacy of a treatment under ideal conditions or the effectiveness of a treatment, how well it works in real-world situations. What has RCT research told us about the efficacy and effectiveness of psychotherapy? Well, that depends on which specific mental disorder is being examined. The type of therapy with the most support is cognitive behavioral therapy. Hundreds of studies have shown the effectiveness in CBT in the treatment of depression, PTSD, anxiety disorders, eating disorders, bipolar disorder, and substance abuse. It has also been found to be effective in decreasing levels of hopelessness and suicidal thoughts in previously suicidal teenagers, and it is consistently found to be equally or more effective than other forms of treatment. Most psychotherapists take an eclectic approach to treatment, drawing on multiple perspectives and tailoring an approach to the specific needs and symptoms of each person. Proponents of eclecticism argue that mental disorders are multi-causal, and that evidence-based treatments have been developed and tested to treat highly specific disorders, while many people have a range of symptoms that don't fit neatly into one category or another. They believe that results of trials cannot be applied to individuals, that determinations regarding treatment should be based on a therapist's judgment. Opponents of eclecticism argue that evidence-based treatment is critical for reducing variability between therapists and ensuring that specific approaches are delivered with integrity. They remind us that many therapists wrongly believe they can perceive patients' problems objectively, and they encourage education about cognitive biases, such as the tendency to favor information that confirms our beliefs, confirmation bias, the tendency to perceive causal relationships when there are none, illusory correlation, and the inclination to perceive biases in others but not ourselves, the bias blind spot. Although psychotherapy doesn't work for everyone, it often improves the lives of adults who suffer from psychological problems and benefits people from a wide range of socioeconomic backgrounds. Interestingly, research has shown that more experienced providers are not always more effective than less experienced ones, and even specific professional credentials are not necessarily a good predictor of therapeutic success. But psychotherapy is just one way to treat mental disorders. Biomedical treatments can be an effective option, in many cases, in combination with psychotherapy. We've already talked about antipsychotic medications, but additional medications have been just as important in the treatment of other mental disorders. Shortly after the introduction of antipsychotics as a treatment for schizophrenia, medications were found that seemed to specifically relieve depression symptoms. Antidepressants fell into two major classes: monoamine oxidase (MAO) inhibitors and tricyclic antidepressants. Both appear to work in part by increasing the amount of norepinephrine and serotonin available for synaptic transmission, though little is known about their mechanisms. These two classes of drugs accomplish this in different ways, but both are effective in alleviating depression, producing marked improvement in up to 65% of patients who take them. But use of medication for treating depression changed dramatically in 1988 with the introduction of the first designer drug called Prozac. Prozac was engineered to act minimally on norepinephrine and dopamine and mainly act on serotonin, and began a new class of antidepressants known as the selective serotonin reuptake inhibitors, or SSRIs. For most patients, Prozac and other SSRIs reduce depression as effectively and completely as MAO inhibitors and tricyclics, but with fewer side effects. SSRIs have become so popular, both for depression and for other disorders, that they are now widely prescribed. For patients who are bothered by the side effects of SSRIs and can't take the tricyclics or MAO inhibitors, atypical antidepressants are available, which work in various ways on serotonin, norepinephrine, and dopamine systems. While some believe these new antidepressants are a panacea, they, like all other medications, have limitations. First, the beneficial effects of the drug fully emerge only after the medication is taken for a month or so. Considerable uncertainty also persists about why each of the antidepressants helps some people but not others. As a result, physicians often resort to a process of trial and error, prescribing a variety of drugs, one at a time, until they find one that helps the particular individual. Medications to treat bipolar disorder are called mood stabilizers. For example, lithium is effective in reducing manic episodes in 60 to 70% of patients with bipolar disorder. Antidepressants are often prescribed along with lithium to reduce depression symptoms. Lithium can also cause unpleasant side effects such as weight gain, feeling sedated, dry mouth, and tremors. Lithium is toxic at higher doses, so patients must have their blood tested frequently. Patients suffering from disabling anxiety are often treated with medications called tranquilizers, technically known as anxiolytics. Most anxiolytics apparently work by increasing neurotransmission at synapses containing the neurotransmitter GABA. Physicians also sometimes treat the anxiety disorders by prescribing a beta blocker, a medication intended to control autonomic arousal. For the uncomfortable feelings associated with anxiety, they might prescribe one of the benzodiazepines. Some of these medications are prescribed so often that they've become household names. They're useful as short-term treatments, usually taking effect in 30 or 40 minutes, for generalized anxiety disorder, panic disorder, post-traumatic stress disorder, alcohol withdrawal, insomnia, and various other stress-related disorders. Benzodiazepines are rarely used for long-term treatment, however, because they're highly addictive and interact dangerously with alcohol. Some of the newer anxiolytics, such as Buspar, are not addictive and are becoming popular substitutes. Psychoactive drugs are increasingly used to treat a wide variety of conditions in children and adolescents. Some researchers have raised questions about whether SSRIs may increase the risk of suicide in some young people, and despite limited research supporting this, the U.S. Food and Drug Administration now requires black box warnings on SSRIs regarding possible increased risk of suicide. There's also controversy around the number of prescriptions for stimulants, such as Adderall and Ritalin, that are being written to treat symptoms of attention deficit hyperactivity disorder. Critics claim that active children are being medicated so they will behave themselves in crowded or understimulating classrooms. While medications are the most popular biomedical treatment, they aren't the only kind. Another treatment that continues to be used, although infrequently, is electroconvulsive therapy, or ECT. It involves using electrical current to induce seizures to help alleviate the effects of severe depression. The exact mechanism is unknown, although it's very effective in alleviating symptoms for people with severe depression who have not responded to traditional drug therapy. However, the memory loss associated with repeated administrations has led to ECT being used only after several medications have failed and when symptoms are severely disabling. There are a couple examples of other brain stimulation treatments too. One is repetitive transcranial magnetic stimulation, or RTMS, which involves the painless application of repeated electromagnetic pulses. When used to treat medication-resistant depression, RTMS has been shown to be as effective as ECT, but without any cognitive side effects. Another treatment, deep brain stimulation, or DBS, includes surgically implanting a kind of brain pacemaker that sends out electrical impulses to specific parts of the brain to help normalize brain activity. A fourth type of brain stimulation treatment, on which efficacy data is still being gathered, is vagal nerve stimulation, which involves implanting a battery-powered stimulator in the chest just underneath the skin. This stimulator delivers carefully calibrated electrical pulses to the vagus nerve. While brain surgery in the form of prefrontal lobotomies is bound to a dark and tragic past, more recently, a highly refined version of psychosurgery has emerged. In very rare cases, neurosurgeons can create small, precise lesions in specific brain areas to reduce severe symptoms of treatment-resistant depression or obsessive-compulsive disorder. So with this array of promising options, who actually seeks treatment? Surveys have revealed that in the United States, only about 40% of those with clinically significant disorders had received treatment in the past year. Common barriers include insurance, the availability of providers, and an individual's motivation to seek treatment and adhere to the treatment recommendations. Public awareness of available effective treatment options is also limited. In a report by the Institute of Medicine, one of the leading reasons those with mental or substance use disorder don't seek treatment is a fear of needing to take medication. In the US, individuals from ethnic minority groups tend to utilize mental health services less frequently than white middle-class Americans. Although reduced access based on socioeconomic status, lack of insurance, transportation, and time may partially explain these differences, even when these factors are taken into account, the disparities in mental health service utilization remain. For example, while women are more likely to seek mental health treatment compared to men, Hispanic and African American women tend to seek and engage in treatment less often than white women. These disparities can be driven by biases in clinical and referral practices that prevent Hispanic and African American women from receiving care, including lack of bilingual treatment options, lack of culturally competent providers, stigma, fear of not being understood, family privacy, and limited information about mental disorders. Perceptions and attitudes toward mental health services can also contribute to disparities. Not seeing the need for help, not seeing therapy as effective, concerns about confidentiality, feeling shame due to stigma. In one study of 462 Korean Americans over the age of 60, many participants reported suffering from depressive symptoms. However, 71% indicated that they thought depression was a sign of personal weakness, and 14% reported that having a family member with a mental disorder would bring shame to the family. Taken together, there's an enormous need for mental health care providers to develop knowledge and skills to become culturally competent. Those providing therapy need to approach the process from the context of the unique culture of each person while integrating cultural and religious beliefs into the therapeutic process. People seek treatment for a wide variety of reasons. Some seek relief from the pain and dysfunction associated with a diagnosable mental disorder. Others suffer with psychological pain that doesn't meet the criteria for diagnosis, but that still may cause significant problems. Others seek help with feelings of loss or grief, anger, relationship difficulties, or life decisions. Treatment can alleviate symptoms, provide education on plausible explanations for psychological symptoms, and help us regain hope that things can get better. Today, U.S. federal law in the form of the Mental Health Parity and Addiction Equity Act requires group health plans and insurers to provide equal copays, visits, and deductibles for mental health and substance abuse treatment as they provide for physical illnesses and medical problems. Inexpensive apps have also become available, and the Food and Drug Administration recently rolled out a new therapeutic class called Prescription Digital Therapeutics, and is attempting to evaluate apps in the same way that they evaluate medication. These new therapies are just beginning to shift the paradigm of care in ways that may better empower both patients and providers.